My name is Sarah Schaefer. I'm nurse practitioner at UW Health here on the endocrine surgery team. I'm just going to share my screen here. And today we'll be talking about thyroid hormone replacement after thyroidectomy. Does that look okay, Dr. Halbeck?
Looks great, thanks.
Okay, all right. So a couple slides not included here. First, I have nothing to disclose. And we'll just go ahead and get started here. So thyroid hormone replacement is typically known as levothyroxine or T4 thyroid hormone. This is the first line thyroid hormone replacement treatment after thyroidectomy or for acquired hypothyroidism or other causes. Not T3. And I say that because T3 is oftentimes a hot topic. We get a lot of patients that ask questions about it, but typically our conversation does go back to, let's start with levothyroxine, give that a try first, and then we can see if we need to talk about T3 down the road. Looked at Hippocrates quick, and those are the brand name forms of levothyroxine that they have listed. There's also a new oral solution for levothyroxine called Ermeza. And I just separated tyrosine out because it is one that is supposed to be a little better for patients with any GI absorption issues, that possibly that drug might work better. So brand name, generic, whatever works for the patient in terms of, what their financial responsibility is, what their insurance coverage is. Our responsibility as providers is just to make sure they understand, the difference between the two, what it means when manufacturers get switched, the need to, recheck levels and possibly adjust medication. So thyroid hormone replacement is best absorbed on an empty stomach. If a patient should ideally wait at least 30 minutes to eat or drink anything other than water. If they can wait 60, they're like rock star, incredible patient. And it's very important that they separate thyroid hormone from calcium and iron by 4 hours. That'll drastically interfere with the amount of medication that gets absorbed. Time of the day really doesn't matter. What really matters, they just get in a routine. Whatever that routine may be. For some patients, that might mean a little bit higher dose because, absolutely this is how life is in terms of when they get up and eat and all that, and that's fine. Advance here. There we go. Sorry about that. Okay, so for the purpose of this talk, I've defined partial thyroidectomy as thyroid lobectomy or hemithyroidectomy. And if that is the operation that's performed on the patient and their pre-op TSH is normal, then great. They go home with no thyroid hormone replacement and then plan to follow up in 6 to 8 weeks. Check TSH and see how well that remaining lobe is doing. After total thyroidectomy, I've split it up into two kind of different categories for thyroid cancer and then for benign disease. So dosing of levothyroxine for thyroid cancer is 2 micrograms per kilogram. Very important to go ahead and just have the patient start taking their levothyroxine on post-op day 1. This limits their time. They could potentially be hypothyroid, or really in theory, they shouldn't be hypothyroid at all. Really now most radioactive iodine ablation is given via thyrogen stimulated and not thyroid hormone withdrawal. So again, patients don't have to experience the unpleasant symptoms and quality of life that comes along with being hypothyroid. So go ahead and start that medication, check the TSH in 6 to 8 weeks. Now for benign disease, in adults, I've put our table here that we use for thyroid hormone dosing. This was a study that Dr. Schneider here at UW and his group did to try to fine tune kind of hitting it on the head the first time around, because it's not a perfect formula. And we found that using BMI, sex and weight seems to get everyone a little closer to euthyroid on the first check, or maybe, sometimes the second or third, but especially important for obese patients that we found this dosing is helpful. So for benign disease, we have patients started either right away on post-op day 1, or sometimes you need to wait depending on, how things went during surgery. For a patient with Graves' disease, maybe a little hyperthyroid, and you want to wait a few days before going ahead and starting that medication. So it's been 6 to 8 weeks. You get that TSH back, and now what? So a TSH is when it comes back low, just to kind of think through, okay, is it a Graves' patient that was profoundly hyperthyroid pre-op? Maybe we're just talking about a lag here with the TSH. Let's check a free T4, have the lab added on, or maybe just get it in everybody and see, if that's normal, then maybe they just need a little bit more time for that TSH to normalize. Biotin's a big one that big supplement people are taking these days. It's also in a lot of multivitamins, and biotin will falsely lower your TSH and your PTH, keep in mind. So something to think about, or are they taking extra pills? And for a high TSH, especially after partial thyroidectomy, are we just getting a lot of pituitary compensation here from thyroid underactivity? Is this, again, checking that free T4 might help sort that out? Do they just need a little bit more time? Are they not taking their levothyroxine? That's a big one. This is a big life change people are going through, having to start this medication. Are they missing doses? Do they need a little guidance to figure that out? Again, taking it with food. Coffee's a big one. People don't see coffee as food. So keep that in mind. Iron, calcium, other medications. Or do they have GI malabsorption, celiac disease, other chronic, diarrhea, vomiting that could alter, how their body absorbs thyroid hormone. One thing that we've found helpful, and I know a lot of other institutions do it, is creating a nursing assessment tool. So when the TSH arrives in your office, the nurses or medical assistants, whoever is on your team, has a go-to dot phrase, delegation protocol, whatever it may be in the EMR, to go ahead and just initiate sorting out, possible explanations for that low or high TSH. They can send it on to the provider, and it really shortens the amount of time that you spend back and forth. Patients get their answer right away, their prescription. Now, hypothyroidism after partial thyroidectomy, let's dive into that a little bit. So incidence is 20 to 40%, but a UAB study not too long ago did find that it's actually as high as 50% in the first 2 years. So you can see it subclinical, where the TSH is high, but the free T4 is still normal, or they could be clinically hypothyroid. Have to sort out, is this something where we can monitor? Should we treat? And the first step really, and hopefully the nurses collected this, or the patient's on your schedule, or you can give a little guidance, to the primary care provider who's managing if needed. How do they feel now compared to before their thyroid surgery? And I think it's really important to use open-ended questions and just have the patient talk, as opposed to giving them specific, are you tired? Are you gaining weight? Are you like things like that. Just with the whole blame everything on your thyroid effect. So that's a great open question just to see, how are things going now how's life now compared to before surgery? And then look at their pathology. Was there Hashimoto's on there? Was there pre-op TSH for going into surgery where we're, like, okay, you're probably going to end up hypothyroid anyway. And then have a discussion with the patient about monitoring versus treating. And, a lot of patients who have a partial thyroidectomy have it because they don't want to be on thyroid hormone. And so monitoring might be the best option for them. So best time or definitive monitoring is great in the elderly when the labs are subclinical, much safer for the elderly population when patients are asymptomatic. Or really, again, if asymptomatic and that TSH is less than 10, monitoring is okay. So check again in a couple months and see where they're at. Treating with levothyroxine, thyroid hormone replacement, definitely if the TSH is over 10, if they're having symptoms, and starting at 50 micrograms a day is usually a good place to start unless they're elderly, then you may want to consider starting at 25. So they have a scenario here where part of the thyroid is removed. Let's say the nodule is benign. Their post-op TSH 6 to 8 weeks after surgery comes back as normal. Let's say it's 2. Great, you're fine, you're good to go. We do recommend continuing to monitor the TSH annually because they are at risk for developing hypothyroidism. And that same UAB did a follow-up study not too long ago that recommended for at least 2 years to check TSH. But there are other articles that advocate for following for longer. So thyroid hormone suppression and replacement for thyroid cancer. Again, starting 2 micrograms per kilogram. I've listed here what TSH suppression means in terms of the goal for the TSH, depending if it's been a partial thyroidectomy or total thyroidectomy. For purposes of this talk, I'm not really going to go into starting thyroid hormone replacement after partial thyroidectomy because it is a bit involved and not quite straightforward. And maybe with these new ATA guidelines that are coming out shortly, we'll have a little more guidance in terms of who for sure should be on thyroid hormone suppression or not. But I've listed the TSH goals there, and it all evolves around their risk for recurrence, low, intermediate, or high. Having a thyroglobulin level at the same time when that TSH is checked 6 to 8 weeks post-op definitely will help you sort out, which, especially for the low risk group, which goal TSH, sorry about that, will be their range. And remember, with medullary thyroid cancer, TSH suppression is not indicated. So this picture is taken directly from the 2015 ATA guidelines, something that I keep close by in the clinic, and outlines the low intermediate risk pathology features on the right, and the farther up on the table you go, the higher risk for recurrence, which indeed would then mean you want to keep that TSH suppressed. So we got some of our mutations in there and pathology findings. Just a couple other things to keep to think about or to kind of stimulate thought. And again, very patient-centered driven would be microcapillary thyroid cancer. And with such a low risk cancer, is TSH suppression needed? And of course, a year after, you want to risk stratify and go from there. A few other things to remember. A lot of our patients want to get pregnant, so making sure that the TSH is optimized and normal before they conceive is important. And then these other certain patient populations outlined below here are groups where when they have thyroid cancer, you have to really think about how much you want to suppress that TSH. I'm not going to go into this, but I wanted to include it in the slides. And this has to, for pediatric patients with thyroid cancer in terms of their risk stratification and TSH suppression recommendations here. This is from the Pediatric ATA Thyroid Cancer Guidelines. And yeah, I know one other thing I just want to mention, and that's I know, a lot of surgeons may not manage thyroid hormone, but this is great information to pass on, especially for those lower risk thyroid cancers that, maybe aren't going to be followed with endocrinology forever. Information for you to kind of outline in a care pathway to or survivor protocol, however it would work, to primary care providers to help them, know kind of what the goals are and manage that long term and, when to refer back. So thank you.